Hello everyone, this is Chris Berigno. Today we are going to talk about the leg and the foot. So recall that the leg is the segment between the knee and the ankle. So we're going to really be focusing on the leg and its three compartments, and we'll go into the foot and the osteology as well. So please take a minute to look over the learning objectives for this lecture. So once again, here is the osteology of the proximal and now the distal shank or the distal leg. So proximally, remember we have a lateral condyle and a medial condyle, and the superior aspect of that makes up a tibial plateau. Essentially, we have a lateral part of that plateau and a medial part of that plateau. Within the fibular construct, we have the head of the fibula. And then if you have a head, you also have a neck, although it's not labeled here. Not so important, but it's kind of nice to realize there. And then we also have a tibial tuberosity on the anterior tibia that gives a nice bony prominence for the quad muscle to insert onto. And just as a review, you may recall that we have a hamstring and a medial compartment muscle and an anterior compartment muscle attaching somewhere in this area through that pes and serinus. And then if we look distally, we have this structure called the interosseous membrane, which is essentially a very thick, broad, strong ligament attaching the tibia to the fibula. And so certainly this part will reinforce the proximal tibial fibular joint, and this part will reinforce the distal aspect of the distal tibia fibular joint. And now we go down below and we have a few other structures, or we'll just have two structures. One is this lateral malleolus and the medial malleolus. And so you would imagine that those styloid processes of the radius and ulna are the equivalents down in the ankle. So these lateral and medial malleoli are the bony prominences of the ankle. The soleal line I'm going to cross out. It's not very important for you to know. And of course, we have that tibial plateau. So here we are at the foot. Obviously, we have a lot of bones, just like in the hand. So we're going to run into a whole bunch of tarsal bones. And these are the equivalent of the carpal bones in the foot. So we have two proximal tarsal bones, the talus and the calcaneus. The calcaneus being your heel bone, and the talus being the bone that articulates with your tibia and your fibula. So here's your medial malleolus. Sorry, I'm going to change that color. Here's your medial malleolus. Here's your lateral malleolus. And here is your tibia going across, and then your fibula somewhere over here. And that is what also called your tibio-talar joint. And then we go more into the midfoot area. So midfoot area, with the prominent bone being the navicular bone. So here's the navicular bone, and it forms the top of the arch of your foot. So this is the arch. Should put top of the arch. That's also called the keystone of your arch. So when you look at construction, if you see an arch above a doorway, there's usually a bone that's shaped kind of like this. And that's called a keystone because it forms the structural integrity of the arch. So we have what are called cuneiform bones. So there are medial, intermediate, and lateral. So here's the medial, intermediate, and lateral. Now I'm not so interested that you need to know the names of these, so I'll put little lines through it. And nor the cuboid, although they are important bones. I just want you to realize that you do have a proximal row, you have a distal row, that the navicular is the keystone and the top of the arch, that you have a talus that's interacting with the tibio-talar joint, and interacting at the proximal ankle, and then you have a calcaneus, and that's your heel bone. Of course, we have your metatarsals, just like we had metacarpals, and you have 5 of them. And just like in the hand, you have a distal, a middle, and a proximal phalanx, and you have a proximal and a distal phalanx of the big toe. Okay, so now that we have the bones in order, let's transition now to the ankle joint. So once again, there are a few components of the ankle joint. We have the tibiofibular joint. That is the articulation here between the tibia and the fibula. And then we have the talocrural joint, and that's this red line drawn in on this diagram, showing the interaction between the tibia and the talus. So the crura means leg, and obviously the talo means talus. Okay, so that's the talocrural joint, also called the tibiotalar joint. Okay, so a few different names for that. So when we look at the distal tibiofibular joint, there's not much to remark on. There certainly is a little divot here in the fibula for the tibia. And then we have some strong ligament here on the front, and we have some strong ligament there in the back. I'm not going to require you guys to know the name of that. And of course, we have the interosseous membrane that's running up between the two bones that helps to reinforce that as well. Again, you don't need to know all that, just so you get the big picture here. We're going to have ligaments that run on either side here to help reinforce that, and we'll talk about that in a second. But know that the distal tibiofibular joint is extremely strong and it has very little movement. And that the talocrural joint is considered what's a mortise and tenon joint. So that's where you have a opening, and within that opening you have something that fits in quite nicely. So this would be the mortise and this would be the tenon. And so that's a mortise and tenon joint. Now what that essentially means is that you're going to have a lot of movement in one plane and not a lot of movement in another. So we're going to have a lot of flexion extension at this tibiotalar joint and not much else, although of course it's not going to be completely restricted in the other planes of motion, but sagittal plane motion predominates. Now, moving on down, here we see a nice side profile, lateral view of the proximal foot, and here we have the talus and that calcaneus. And this interaction between the talus and the calcaneus is called the subtalar joint, which means the underneath the talus. And so this is a very broad interaction. There's a few facets and there's lots of different very complex motion. You don't need to know so much about the complexity of the motion. However, I want you to realize that here is where we get much more motion in the frontal plane and also in the transverse plane. So at the ankle, a lot of people say the ankle is a hinge joint. Well, the talocrural joint is a hinge joint. And that gives, so the talocrural joint gives sagittal plane motion, but here at the subtalar joint, we have a lot of frontal and transverse plane motion. All right, and that's all we'll talk about here. Okay, please don't get freaked out by this slide. This is a medial view, so we're getting a nice kind of picture of this arch. And we have this navicular bone that is forming that keystone of the arch. So you see it's at the top of the arch. So we have a couple important ligaments here. Medially between the tibia and the talus and calcaneus, so the talus is kind of hidden up under here. And here's, of course, the calcaneus. Between the two, we have a very large, robust ligament. I'm going to draw it in as its whole entity. It's formed by 4 ligaments. You don't need to know the name, but this is, in its entirety, the deltoid ligament. Just like the deltoid muscle, we have a deltoid ligament. Okay. And so you would need to know that the deltoid ligament resists ankle eversion. Now, what is eversion? I think I need to go back to a previous slide. So I'm going to do that here in just a second to talk about eversion, inversion. Okay, so we already mentioned that the foot moves in the sagittal plane. So the sagittal plane would be an ankle. If we're looking at a side profile, it goes up, or dorsiflexion. That's kind of bringing the toes up to, this is supposed to be the leg, by the way, and this is the foot. Or we go down, kind of pointing your toes like a ballerina. That's plantar flexion, or going up on your toes. So that's a sagittal plane motion. Well, this down here is a frontal plane motion. And so bringing the foot, this is medial, bringing the foot inward. If you were to do this with both feet at the same time, with your feet out in front of you, not standing, but your feet, if you're sitting in a chair and the feet are out in front of you, and you do this with both feet, the soles of your feet would be facing each other. So that's called inversion. Or if you take both of your feet and turn it outward, where the soles of your feet are facing away from each other, that's eversion. And so we're back here at this deltoid ligament, and you could imagine that if the sole of the foot turned away from us here, that would be eversion, and these ligaments would get taut. Now, the deltoid ligament is extremely strong, so strong that it's somewhat rare to strain this ligament. It's more common actually to get an avulsion fracture. An avulsion fracture where the end of your medial malleolus is fractured off from the tip of this tibia because this deltoid ligament is so strong. While we're here, I want to talk about this plantar calcaneonavicular ligament a little bit. So this is also called the spring ligament, and it extends from your navicular to your calcaneus. Okay, and here it is. So I tried to do that in another color. There's your spring ligament. And this is a critical ligament to help hold up your arch. So again, here's your arch. If you lesion your spring ligament, then your arch collapses downward. So now let's take a look at the lateral side of your foot. Now again, don't freak out. You don't have to know much here. You see a little bit of a lateral arch of your foot. Now your lateral arch is not as pronounced as your medial arch. As far as the ligament structures are concerned, you really need to know that there is an extensive network of ligamentous structures for your ankle, mostly attaching your fibula to your calcaneus and to your talus. And this is your lateral infrastructure of ligaments. The only one you need to know by name is your anterior talofibular ligament. And the reason you need to know it by name is because many people sprain their anterior talofibular ligament. So this is your anterior talofibular ligament. So it's more of the anterior part of this construct of ligaments. And when you invert and you plantar flex, so when the foot is pointed downward and the sole of the foot turns inward, this ligament becomes taut and you sprain it. And let's take a look at. So here's that plantar flexion inversion movement, and you end up lesioning your ATFL, or your anterior talofibular ligament. And if any of you have played any sort of athletics, especially field athletics growing up, or court athletics, basketball, you come down and your ankle might look a little poofy like this. It's extremely painful. And then after this is acute, this is let's say an hour or two afterwards. Let's put 1 hour. And then this is what it looks like 2 to 3 days afterwards. It looks like you really wreaked havoc on everything in the foot and the ankle. So again, this is extremely painful acutely. It's extremely painful chronically. It's very hard to walk on. And again, many of us go through this in our sport career. And so this would be an ATFL sprain. Okay, let's now move into the anterior compartment of the leg. So just as we saw in the thigh, the leg has 3 compartments. We have an anterior and a posterior compartment. Now, if you recall, in the thigh, we had a medial compartment, but in the leg, we have a lateral compartment. So we have an anterior, posterior, and lateral compartment. And we are going to now talk about this compartment right here, the anterior compartment, which is separated from the posterior compartment by the interosseous membrane. Let me get a new color here. The interosseous membrane here, connecting the tibia to the fibula. And it's also separated by the lateral compartment by a intermuscular septum. And it's also separated by the posterior compartment with this bone, which is the tibia. So there are 3 main muscles of this anterior compartment, with the 4th being variably present. And we're not really going to worry about this 4th muscle. So let's just really focus on these 3 muscles that are shown here, the tibialis anterior, the extensor digitorum longus, and the extensor hallucis longus. The tibialis anterior and extensor digitorum longus are more superficial than the extensor hallucis longus. So you can see that hallucis muscle kind of nestled up in there. Okay, well, let's take a look at these 3 muscles. So the most prominent muscle here, we have the tibialis anterior, and I will say it's probably the most important muscle as well. Its primary action will be to dorsiflex the foot. And we use dorsiflexion of the foot when we are swinging our leg through during normal gait. If we don't have dorsiflexion of the foot, we end up catching our toes on the ground. So this tibialis anterior extends from the tibia and goes medially to insert onto the first metatarsal, and it's going to help pull up on that foot for dorsiflexion. It will also help to invert, but that's much less important than the dorsiflexion. Extensor hallucis longus is a muscle that extends to the great toe. So hallucis equals great toe, and it really insert onto that distal aspect of the toe. And again, not so important that you know where it's coming from, although it's nice to know that it's coming from somewhere in the mid-leg there, and it's extending distally onto that great toe to help dorsiflex the foot and to help extend, of course, the great toe. And then we have extensor digitorum longus that will insert onto the 4 other toes, and of course it will also help to dorsiflex and then extend all the other digits. So it's important to look at the blood supply anteriorly from the leg going into the foot. Why? Because when you're working with your patients, you may want to check a pulse at the foot. And so the most common area to look for distal circulation is right here. And so this is what's called the dorsalis pedis artery. And the dorsalis pedis artery comes from the anterior tibial artery, and the anterior tibial artery comes from the popliteal artery. We don't see the popliteal artery because the popliteal artery is actually in the back of the leg. So the artery is somewhere in the back of the leg. We can't see it, and then it's going to give off the anterior tibial artery that goes to the front of the leg and runs up underneath the tibialis anterior, which is kind of nice because you have the anterior tibial artery running up underneath the tibialis anterior muscle. And so you are wondering if your patient has any decent circulation in their distal leg, and when circulation is compromised, usually the compromise manifests itself more distally than proximally. So you're really concerned about their foot. So you want to take a pulse down here. And so you would ask them to extend their great toe. Okay, we're down here now. You're going to ask them to extend their great toe. This extensor hallucis longus tendon is going to then be prominent in the foot. So here's the tendon. And then you would feel for the pulse proximally, just lateral to the extensor hallucis longus tendon, and that's where you would rest your fingers. So the extensor hallucis longus tendon is really the giveaway for where that pulse is located. Okay, now let's shift towards the lateral compartment of the leg to talk about the muscles we find there. So in the lateral compartment, it's quite easy. We have two muscles. We have what's called a fibularis longus and a fibularis brevis. Obviously the longus being longer than the brevis. And these muscles as a unit will help to evert the foot. So you can see that they're both attached to the fibula. They're going to extend down just posterior to the lateral malleolus. And they're going to insert onto a couple different areas of the foot. The longest, because it's long, travels up underneath the foot to insert onto the base of the first metatarsal bone. But the brevis is going to extend down, again, posterior to the lateral malleolus, but attach to the base of the fifth metatarsal. So the innervation of these two compartments, the anterior compartment and the lateral compartment, are both served by branches of the common fibular nerve. Now, if you recall, the common fibular nerve came through to this area via the sciatic nerve. So it was one of the two components of the sciatic nerve, the other being the tibial nerve. And again, this is posterior in the leg, so we wouldn't see it here, but it would traverse laterally. And it comes around the head of the fibula. So this is the head of the fibula. And so this is a point, common point of lesion of the common fibular nerve. It's very vulnerable right there. And so the common fibular nerve then branches into its two components, the deep fibular nerve and the superficial fibular nerve. The superficial fibular nerve goes to the lateral compartment. So it's going to innervate these two muscles. And then the deep fibular nerve is going to go to the anterior compartment to innervate these muscles. They also both have cutaneous innervation, with the superficial, just like in the hand, the superficial radial nerve had much more cutaneous responsibility. It actually had all the cutaneous responsibility, but in the leg, it has most of it. It has all of this cutaneous responsibility, and then it does something funny near the toes. It splits, and there's this little spot in between the first and second toe for the deep fibular nerve. So just this area, this web space between the first and second toes is served by the deep fibular nerve. And how does that do that? Well, we can trace it down. We can trace this deep fibular nerve down. It's very, very deep, very, very deep, and it just continues on. And right here it branches and gives two digital branches right there to the web space. Everything else is the superficial fibular nerve, and we can see that here. Here's the superficial fibular nerve, and then just like the superficial radial nerve where it has this extensive branching, it serves the whole dorsum of the foot with the exception of that first web space. So here we have the posterior view of this popliteal artery. Now, how did the popliteal artery become the popliteal artery? If you recall, if you look at the way top of the picture here, we have the femoral artery. That's anterior. It goes through the adductor hiatus, and once that femoral artery passes through the adductor hiatus, it now becomes the popliteal artery. So from this spot to its branching from there, that's the popliteal artery. Then the popliteal artery gives off this anterior tibular artery, and ultimately, through some branching, gives off a posterior and a fibular. This is big picture stuff. This isn't so important that you know. It's just you may want to know that if there's a compromise, let's say in the femoral artery way up here, if there's a compromise to the femoral artery, everything downstream in the leg can get compromised as well. So what does the anterior tibial artery do? Well, it serves the anterior compartment. What does the posterior tibial artery do? It serves the posterior compartment. And then, of course, the fibular artery. Remember that fibularis longus and brevis. Those are in the lateral compartment. We'll also call that a fibular or lateral compartment. That's really what you should know. That each has its own artery. It almost has the same name as the compartment. And it's all brought by the popliteal artery, which was brought by the femoral artery. Now let's transition to the posterior compartment, the largest compartment of this of the leg. So here we are in the posterior compartment, and the most superficial muscle we'll see is the gastrocnemius. So we have a medial head of the gastrocnemius on the great toe side, and then we have a lateral head of the gastrocnemius. So it's two heads, but one muscle, and it gives off a very long tendon that's going to merge with another tendon or two. This long tendon here is the tendon of calcaneus, but then down here, when it merges, is now called the Achilles tendon or the calcaneal tendon. So the Achilles tendon is where the gastrocnemius tendon merges with other tendons, and it's going to insert onto the calcaneus. Now, if we reflect the gastrocnemius, which is seen here on the picture on the left, we can now see a very large, very broad muscle called the soleus muscle. Now, the soleus muscle originates from the tibia, while the gastrocnemius muscle originates actually from the femur. So the gastrocnemius can act at the knee. So what would it do? It would do knee flexion, while the soleus only acts directly at the ankle, only moves the ankle. There is another muscle here, the plantaris. This is sort of like palmaris longus, and because we're in the lower extremity, we're just going to put a line through that. So it's a small muscle. We call this a vestige muscle. We don't think it really does very much, although it hypertrophies when we do a lot of jumping. But generally speaking, it doesn't really do much, so we're not really going to pay much attention. The soleus muscle, however, is extremely important. We use the soleus muscle during gait, during normal walking, almost exclusively, while the gastrocnemius is called upon for more explosive activities, such as jumping. There's an M there, jumping, or sprinting. Something where we have we need a lot of force, a lot of speed in the contraction, versus day-to-day activity, we're asking the soleus to do a lot of action all the time. These muscles in the posterior compartment are innervated by the tibial nerve, which was again one of the other components of the sciatic nerve. So remember, the sciatic nerve was the tibial nerve and the common fibular nerve. I'm just going to kind of cross this out for now because we're in the posterior compartment and everything's innervated by the tibial nerve. So we have that gastrocnemius coming down. We have the soleus coming down, and they form this common tendon called the Achilles tendon. And we might call upon this tendon to support a very large leap or a cut, if you will, where you plant the foot and try to change direction. And so the gastrocnemius fires violently, and then we rupture the calcaneal tendon, and this is called an Achilles rupture or calcaneal tendon rupture. And a person who sustains this might feel a pop or a snap. This occurs very often in people in their 30s and 40s, and otherwise relatively infrequently in the younger population and the older population. So these are common in weekend warriors, in the has-beens of sport, those like me who might have participated in some sort of field or court sport and then try to get back into it later on in life after taking some time off. And you can look at their nice narrow tendon over here and then a very broad scarred tendon on this side. This is even after it's been fixed, although in this person I see some black and blue down here. This is probably more acute, but even after things have been fixed, this is still very broad, a broad tendon over here. So now we're looking deep to the gastrocnemius and to the soleus. So we've resected, here's the cut edge of soleus, and we're looking at some other muscles. So we had some extensor hallucis longus, we had some extensor digitorum longus, so we must have a flexor hallucis longus and digitorum longus, so we see those here. We had a anterior tibialis anterior, so we must have a tibialis posterior, and we see that here as well. So the tibialis posterior is going to extend to, again, through the medial side of the ankle, posterior to the medial malleolus, as do the flexor digitorum longus and flexor hallucis longus. Obviously, the digitorum longus is going to flex the digits, the lateral 4 digits. The flexor hallucis longus is going to flex the great toe. The tibialis posterior is going to play a critical role in holding up the arch of the foot. And we'll see that here in just a second. While I'm here, I want to talk about the popliteus muscle most proximally. The popliteus muscle connects the femur to the tibia. And all you need to know about the popliteus muscle is that it unlocks the knee. It unlocks the knee. So when this contracts, when you're standing straight and you want to bend it to start to walk, this muscle will contract this way. It will, you don't need to know this, just giving you a big picture. It will laterally rotate the femur on the tibia and will help to unlock the knee. So I think I jumped the gun on the previous slide, going into detail on the tibialis posterior, digitorum, and hallucis. But as a review, here's that tibialis posterior going medial to the calcaneus. So if it contracts, it's now going to be a powerful inverter. It's going to bring the sole of the foot inward. It also can plantar flex, and it has this broad attachment on the underside of the foot. Not so important, but however, it's nice to appreciate this attachment because then it'll kind of help you to know its function. It's really going to bring all these bones inward towards the inside for inversion of the foot at the ankle. It passes posterior to the medial malleolus, so it can also plantar flex. So inversion and then plantar flex. So this is a primary muscle which holds up the arch of the foot. And then we have flexor digitorum longus and hallucis longus. Here is that popliteus and its muscular attachments. It's going to contract and laterally rotate the femur. Now, all these muscles, all these muscles in the D group of the posterior compartment, so those muscles outside of the gastrocnemius, soleus, and that small plantaris muscle, they are all going to travel posterior to the medial malleolus. And in order, they go the tendon of tibialis posterior, the tendon of flexor digitorum longus, and then the tendon of flexor hallucis longus last. And in between, we have an artery and a nerve. So we have a nice little mnemonic to remember that. Tom, Dick, and now Harry. And some people say Tom, Dick, and very nervous Harry, because we have a Tom is tibialis posterior, Dick is digitorum, the A is the artery, the V would be the vein, it's not listed here, the nervous would be the N in nerve, and the H would be, the hairy would be the H for hallucis. And so that's a really reliable way to differentiate these muscles, and it helps the students who are learning their gross anatomy in the gross anatomy lab tell which muscle is which by just looking at the order in this area. So what is this area called? Well, it's called the tarsal tunnel, just like we had a carpal tunnel. So here, this would be the equivalent of that median nerve, but we have the tibial nerve crossing through this tarsal tunnel. And let's move on. So as I mentioned in a previous lecture, that the innervation to the sole of the foot is quite important. Our foot is what's interacting with the ground for the most part. And since we're biped creatures, and so if we have a decreased sensation in our foot, we might not be able to feel the ground very much, and we're at risk for all kinds of problems. So here we see a tibial nerve and its cutaneous innervation on the heel. And then the tibial nerve splits into two branches. And we don't need you guys to memorize this. Really, what I would like for you to know is that the distribution of the tibial nerve is almost the entire sole of the foot. Medially, we have the saphenous nerve, and if you recall, the saphenous nerve came from the femoral nerve. So it's the distal branch, cutaneous branch of the femoral nerve medially. And then we have this structure called the sural nerve that has the very far lateral area. Take-home message again is that the tibial nerve accounts for, I'm going to make this up, but it looks like at least 90% of the cutaneous innervation for the bottom of the foot. And that's what you need to know for this slide. So here's the global cutaneous innervation for the thigh and leg. And here we see that tibial nerve that we were just talking about, and we see the heel and, of course, the bottom of the foot. But notice that that sural nerve that was mentioned really comes off the tibial nerve as well. So we have the lateral distal leg and the lateral foot all served by the tibial nerve as well. Here we see that saphenous nerve that's going to capture really the whole medial aspect of the leg and that little aspect, that medial aspect of the foot, including the medial malleolus. And then we have the lateral cutaneous nerve, or coming from the common fibular nerve, that helps to serve this area of the upper leg. We have the lateral cutaneous nerve of the thigh. Now, we haven't seen this yet, but this comes from the pelvis. It comes from high up in the pelvis and extends down just anterior to the ASIS to then branch and serve this area. That's the lateral cutaneous nerve of the thigh, or the lateral, we also call this the lateral femoral cutaneous nerve. If you recall, we had that obturator nerve serving the medial compartment, and then, of course, some other cutaneous branches of the femoral nerve, where the femoral nerve just kind of starts branching and then gives one solid branch down called the saphenous nerve. Posteriorly, We have the posterior cutaneous nerve of the thigh. This comes out with the sciatic nerve out of the gluteal region. Some of us have seen that. Some of us who have been dissecting have seen that already. So I think we have one example of that in the lab. Of course, medially, we still see the obturator nerve, and that basically covers the entire innervation of the leg, because here again we have the saphenous nerve on the medial side. Dermatomally, we've already mentioned on the sole of the foot we have 4, 5, and 1. Sorry, it's hard to read that. 4, 5, and 1 from the great toe laterally to the pinky. In the posterior leg, you see on the lateral leg we have S1. On the medial leg we have S2. And anteriorly, we have that L3 dermatome kind of reaching around from superior to inferior. It goes medially, as does L4 to get down to the medial aspect of the foot. And then L5 is more of the anterior aspect of the leg. Now, regarding the sole of the foot, we are not going to go into detail of any musculature in the foot. So there are no intrinsic muscles of the foot that you guys are responsible to know. However, just again, a big picture thing, you might imagine that we have some hallucis muscles, so some hallucis brevis muscles. Remember, we had flexor hallucis longus, extensor hallucis longus, so we must have some brevis muscles, and so those would be contained in here. And we have some of those digiti minimi muscles over here as well. Again, that's just big picture. You don't really need to know the names of those. We also have some other digitorum brevis muscles as well, and various other structures up in this structure. But just like in the hand, we have what's called a plantar aponeurosis. Gives a lot of structural integrity to the foot. So here we see this plantar aponeurosis. I'll color it in orange. So this whole vast structure, just like we had a palmar aponeurosis, we have this plantar aponeurosis. And so this plantar aponeurosis can get inflamed, and it's usually more on the proximal aspect of it. And this inflammation is called a plantar fasciitis. And so this happens for a variety of reasons. One, we might start developing a flatter foot, so this navicular bone may be dropping down. It puts more stress on this plantar aponeurosis. Also, we might have increased weight gain. Think either, just the general freshman 5, if you will, or pregnancy, or middle-aged male who is getting too much good cooking at home or going out to eat a lot, and therefore gains some weight on that side. Or somebody who changes jobs, is now standing a lot more, or somebody who's taken on a new new exercise regimen, such as distance running, might develop a plantar fasciitis. This is simply a review of the veins. In here, for completion, as far as the foot is concerned, we have that dorsal venous arch that is contributing to the greater and to the small saphenous. We are nearing the end of the presentation. A very common injury that occurs generally in the younger population and the athletic population is shin splints. And I include this in at the end because it requires a little bit of knowledge about the anterior and posterior musculature. So shin splints is pain that's generally felt at the tibia. So it could be here on this side or here on this side of the tibia, depending on what muscle is involved or what trauma is involved within the muscle. So it could be a tibialis anterior problem or a tibialis posterior problem, which causes small tears in the periosteum of the tibia bone. So again, with increased running, or let's say an increased walking regimen, again, maybe weight gain, or a change in behavior, or some really rotten shoes, perhaps, you start to roll inward a little bit. Maybe you start to evert a little bit. You lose your arch a little bit, and you could start to develop these periosteal um, ruptures where the muscle is attaching into the bone. And so you have these little micro tears, and this can be quite painful. It usually resolves, or at least the pain resolves, when you stop walking, but it increases again if you start to walk again. And so you might imagine that quite a bit of rest, ice, compression, and elevation is the recipe for success here, plus changing the shoes maybe, or addressing the behaviors or the weight gain or whatever it might be. Okay, the last clinical correlate and last slide of the presentation is going to be on bunions. So what are bunions? We've all heard about bunions. Bunions are pretty interesting because here we have an normal alignment of a foot. Here we have the first metatarsal. Okay, so this would be the metatarsal head. This would be the metatarsal base. And here's the second metatarsal, and they run relatively parallel to each other. On the picture on the left, we have a metatarsal at the metatarsal head and a second metatarsal. And so you can see that there's quite a bit of extra space here relative to that one. So what's going on here? Obviously you're getting some adduction of your first metatarsal. So the first metatarsal is adducting here. But also, really importantly, is that the bone is internally rotating. The bone is internally rotating, and therefore we have a few sesamoid bones on the underside of the first metatarsal head. Now, sesamoid bones are little bones that look like sesame seeds, and they're usually integrated in some tendon. So we have a tendon running along here, encapsulating the bone, and the tendon continues onward. Well, as the metacarpal internally rotates, the sesamoids move externally, and therefore they can get stuck between the first metatarsal head and the second metatarsal head. So they get stuck between here and here, and this can be quite painful. So many times people get these fixed because the deformity is not very visually appealing. But oftentimes people are willing to live with it because functionally they're still functional. But once this sesamoid bone gets stuck in here, now we have pain, and anytime someone has pain, they want it fixed. So people seek help once that sesamoid gets stuck in there and produces pain. So that concludes this lecture on the leg and the foot. I appreciate you guys hanging in there and listening.